Welcome to Medicine Grand Rounds. Uh, Today we have a very interesting topic to discuss, which is disability and how it affects care of patients. We have two speakers, Doctors Martin and Campbell. Dr. Barry Martin is an associate professor of medicine in the Division of General Internal Medicine. He received his undergraduate and MD degrees from Louisiana State University and did his internship in family medicine at the Medical University of South Carolina, MUSC. He has a long-standing interest in disabilities, especially as it relates to patients with Down syndrome. Eric Campbell is a professor of medicine in the Division of General Internal Medicine, and he's the director of research at the Center for Bioethics and Humanities here at the University of Colorado. He received his bachelor's degree and his PhD from the University of Minnesota, where he developed a focus on healthcare disabilities for patients secondly, challenges faced by IRBs and investigators. And thirdly, industry-sponsored research and conflicts of interest between the investigator, the university, and industry. He first became a faculty member at Harvard and was there for a number of years and rose through the ranks to professor of medicine. And we were fortunate to recruit Eric here a few years ago to the University of Colorado. He's served on a number of national committees, including committees at the NIH and the National Academies of Medicine, and he has an outstanding funding record, track record of training, and a number of very high impact publications. So I really look forward to this discussion on disability competent care. I think Dr. Martin is going to present first, and then we'll transition to Dr. Campbell. Please put your questions in the Q&A box, and we'll sort them out and address them during the discussion period. Dr. Martin.
Thanks so much, and thanks for the opportunity to talk about this topic, which has been my clinical passion for the past almost 30 years, and I hope I can spark some interest on the part of more of you. If I can get my slides to advance. There we go. Unfortunately, I have a few financial disclosures to make. By the end of this talk, I'm hoping that you will understand how prevalent disabilities are, appreciate the health disparities that patients with disabilities face in our systems. I'll talk about why you should care about this and what you can do this afternoon to make your practice in your location more disability competent. And the way we're going to do this is defining what I mean by disability, the prevalence of disabilities, the health disparities. We'll talk about some of the reasons why you should care about this and give you some tips on how you can be more disability competent. We were asked to start our presentation with a patient, so I'm presenting a sort of hypothetical patient, but your assistant comes and says your next patient appears to have very low IQ. The history is provided by surrogates. The patient is non-ambulatory, incontinent of urine and stool, poor saliva control, dependent on all activities of daily living. And you might or might not be excited to see this patient. You might think maybe you're not well prepared to take care of a patient like this. And in fact, if it was this patient, nearly all of you will have had some training in taking care of patients like this. May have been a while back in medical school, but you had some training. You probably didn't have any training on taking care of a patient like this, who has cerebral palsy, and in fact, probably doesn't meet most of the things that your medical assistant assumed. And in fact, this person with cerebral palsy completed a half Ironman triathlon. So some of your assumptions about what meeting this patient was going to be like might be completely wrong. So what do I mean by disability? And this is the definition by Health and Human Services. Difficulties in hearing, in seeing, in concentrating, remembering, or making decisions. mobility, walking or climbing upstairs, activities of daily living, such as dressing or bathing, or instrumental activities of daily living, such as doing errands alone. So people who have difficulties in these areas are what I mean by a person with a disability. Another way of thinking about these issues are that these are people who have challenges with sensory, cognitive, or mobility issues. Or another way to think about it is that there are people who were born with a disability, such, for example, Down syndrome, people who acquired a disability from a spinal cord injury or from disease, or people who are aging into disability. And if we don't die prematurely, every single one of us will at least age into a disability. And I want to talk a little bit about how medicine interacts with people with disabilities. And I thank Megan Morris on campus for these slides about this and the thinking about this. So generally, disability has been considered the equivalent of being unhealthy. And if people are unhealthy, that leads to poor outcomes. And so if we want to improve on health outcomes, the way we can accomplish this, of course, is by doing away with disabilities. And so a lot of what happens in medicine is trying to prevent disabilities. And while that's not a bad thing, it probably is not going to get us where we want to be with people who are born with disabilities, acquire them, or aging into disabilities. We are not going to prevent all of those. So the real issue is not that people have a disability, it's how our cultural and social environmental factors affect people. And as you can see here, there are lots of different challenges that affect people with disabilities that really have little to do with their physical state or cognitive state. And what we're going to talk about today is disparities in quality and access to healthcare and how that leads to poor health outcomes rather than the person's disability per se. When we look at prevalence of disabilities, if you look at the table on the right, you can see that among the patients that we generally take care of in adults, even in the younger patients, age 15 to 24, 5.3% have a severe disability. So quite prevalent even among that population. As you get into middle age, 55 to 64, 20% have a severe disability, and that climbs to more than half in our patients 80 and over. So disabilities are not at all uncommon. They're very common and affect lots of our patients, and is a big population that we often don't pay enough attention to. And you can see on the left the numbers I think this was 2010 data, showing the numbers of patients in the United States who live with these various disabilities. So very common. And people with disabilities experience significant health disparities. These are data that Susan Haverkamp published in 2015, showing that as you look at either people with no disability, any disability, or intellectual disability, there are great health disparities. Report of poor health, obesity, using tobacco, no physical activity, are all much worse in people with disabilities than in people without. And when you look at healthcare services, again, in some cases, people with intellectual disabilities don't do too badly. But in general, people with any disability are worse off in healthcare services than people without disabilities. So disabilities are very common, and people with disabilities experience many health disparities. So now I'm going to talk about why you should care about these disparities and this patient population. And the first thing is it's a moral obligation. And I really feel like the talk should be able to stop right here. These are people who are parts of our communities, they're parts of our families. Clearly, we should take care of them the same way we take care of everybody else. So I should be able to stop here and that should be the end of it. But unfortunately, it really doesn't work that way. So I'm going to talk some about the legal obligations in taking care of people with disabilities. And when I think about legal issues, I often think of Patty Gabbo, who many of you know. I served on the board of Colorado Access with her for a long time, and she would always ask very insightful questions, especially about legal issues. And one of the ones that Patty would ask often that I found useful was, how illegal is it? And I can tell you in this case, it really is very illegal if we don't treat patients with disabilities the same as we treat all of our other patients and make proper accommodations for them so that they can get equal care to everyone else. So there are these 4 areas that I'll talk some about. Section 504 of the Rehabilitation Act, which said that, and I'll go into this, but any entities that get federal funding could not discriminate against people with disabilities. The Americans with Disabilities Act that said whether you get federal funding or not, you can't discriminate. Section 510 of the Rehabilitation Act, which laid out some of the things that need to be done for accommodations. And then OSHA, which is not always thought of in this context, but I think makes some sense. And I'll point out a paper published by Dr. Campbell previously in Health Affairs, looking at the knowledge of physicians about their legal obligations when caring for patients with disabilities. Unsurprisingly showed that most physicians have a very poor understanding, but not you. You'll have a good understanding after this. Sorry, Section 504 of the Rehabilitation Act again said any program or activity receiving federal financial assistance, and by program or activity, you can see down here means operations of, for example, healthcare organizations. So this does apply to us in our institution. So we cannot discriminate against people with disabilities. Much better known is the Americans with Disabilities Act, which prohibits discrimination against individuals with disabilities in everyday activities, including medical services. And I pulled out some language directly from the Americans with Disabilities Act, which says that a public accommodation needs to be made to ensure that no individual with a disability is excluded, denied services, segregated, or otherwise treated differently than other individuals because of the absence of auxiliary aids and services, such as the acquisition or modification or equipment of devices. And certainly my reading of this doesn't say that it's okay to have a special place where people with disabilities can go where they can access services. It says that they need to be treated the same as anyone else. And so as we'll talk about later, if a person who doesn't have a disability is going to lie down on an examination table to have their abdomen examined, we need to be able to do this same level of treatment for a person with a disability who is in a wheelchair, for example. Section 510 of the Rehabilitation Act laid out technical standards for the accessibility of medical diagnostic equipment, how big examination rooms need to be, how mammogram machines can be accessible. All of these are laid out very clearly and are very accessible. Another issue around legal obligations under taking care of people with disabilities, I think, is under OSHA. Worker safety in healthcare settings. If you are having to move patients physically by having 2 or 3 or 4 people bodily lift patients out of their wheelchair onto an examination table or into a bed, the chances of someone getting hurt with a back injury or something else is, I think, fairly high. And so for all of these legal reasons, including OSHA, we need to pay attention to how we are able to care for people with disabilities. And another issue, so there's the moral obligation, there's the legal obligation. It's actually the law that we do this. There are issues of malpractice. The 2 most common reasons why doctors are charged with malpractice are failure to diagnose and improper treatment. And to me, it seems obvious that, again, if a person who has a disability can't be moved from their wheelchair onto an examination table to have their abdomen examined, it's going to be very easy to miss a diagnosis and treat that person improperly. And that could very well lead to not only poor outcomes, tragic outcomes, but to malpractice claims. So how can we be more disability competent? So I'm going to talk about some of these: financial issues, attitude, architecture, communication. I'm not going to talk too much about systems issues, but I will talk about a little bit about lack of medical training, which I think is actually the least important of these barriers. Financially, this doesn't have much to do with disabilities or the access of people with disabilities have or don't have to medical facilities. But the fact is that in our country, most people with disabilities are insured by Medicaid or Medicare, which are not good payers. And so it can be very difficult for people to get access to healthcare services. That's less of a barrier in our institution, I think, with the advent of the upper payment limit process through Centers for Medicare and Medicaid Services, but can still be a significant issue, especially for Medicaid patients. At least on the primary care front, federally qualified health centers they get better reimbursement under Medicaid, so it should work better for them to see people with disabilities. But they often are overall strapped for cash and have tight appointment times, which don't always work well for people with disabilities. And for people with mental health issues, the way the system works in Colorado is that the community mental health centers are funded to treat mental illness, not for behavioral problems related to neurologic issues, for example, autism or Tourette's disease. And so all of these present barriers, significant barriers to people with disabilities to getting access to healthcare services. But there are others. The attitude of the staff and everyone in the healthcare institution, and Eric is going to talk more about that, the attitude and perceptions of physicians about taking care of people with disabilities. But one of the biggest challenges is that people make assumptions and that those assumptions are often wrong. In the hypothetical patient I presented, the medical assistant assumed that because the person had cerebral palsy that they couldn't do anything for themselves and someone else had to speak for them. And in my hypothetical example, it may have been that none of that was true, but we often make assumptions. For example, providers might assume that a woman with quadriplegia doesn't need birth control when she needs it just as much as anyone else who's of childbearing age. Issues of architecture and equipment in offices. This is, I think, a very interesting study done in California. More than 2,000 practices that take care of a lot of patients with Medicaid. And they surveyed these centers to see how accessible they were. So if you look at the usual ADA kinds of things, parking and exterior access, entrance and interior space, and even the interior of the provider's office or examination rooms, if you look at the dark black sections, you can see that most practices were very compliant with these things. It's surprising that they weren't better. These are very basic, having handicapped parking, doors with push buttons. Those are all very standard things that we know are required under Americans with Disabilities Act. But when you go a little further and look at, did these offices have height adjustable exam tables and accessible weight scales, wheelchair accessible weight scales, you can see that very few did. Less than 10% had a height adjustable table and less than 5% had accessible weight scales. Unfortunately, the survey did not look at whether there was a way to transfer people from wheelchairs onto examination tables. I think that percentage probably would have been even less. So height adjustable examination tables. The table on the right here is our typical examination tables. There's a little stool that pulls out for the person to stand on. And we've all seen our older patients, especially if they're overweight, try to stand on that little platform, turn around and sit on the high ledge of the table. Tables like this are convenient for providers, so we don't have to bend over as we examine patients. But they're not convenient for patients. And as you can see, the table on the left, which is height adjustable, a person in a wheelchair who has upper body strength can probably transfer themselves over to it, or people who use a walker, cane, crutch, something like that, can walk up to the table, turn around, and sit down without the balancing act on the little platform. Wheelchair scales, or you can weigh the wheelchair, you can weigh the person in the wheelchair so you know what the person weighs. People say, well, they're big, they take up a lot of room, but not necessarily. They can fold up, they can be, as you see on the right, they can be easily moved, put in a place that is not in the way when there's no one with a wheelchair who needs it, but easily can be taken out and used for a person in a wheelchair when needed. And a lift system. Some way, you can see on the left, there are people trying to manhandle this woman to get her out of her wheelchair onto the, looks like a physical therapy table, which is pretty low at least. The ideal system is an overhead lift, as you can see in the center section, where a person can be safely transferred and with dignity transferred out of their chair onto a bed or examination table. Systems like that are expensive, but a Hoyer lift system, as you can see on the right, are not very expensive, less than $1,500. And you'll hear they take up too much room. Where are we going to put this lift? There are many, many different folding lifts that can be easily stored in a storage room or closet when they're not needed and brought out when they are needed. So these are not huge changes, not expensive changes, things that could be done this afternoon if we have the will to do it. Communication matters a lot to people with disabilities, and so these are just a sampling of things that should not be said or that we should say instead. Mental retardation is very outmoded in the last 15 or 20 years. People call it the R word. Anything that children use in the playground to tease each other is something that lots of people don't want to be called. And so a better word, a better term is intellectual disability. Any ick words like he's quadriplegic, she is epileptic, that labels the person with the disease rather than putting the person first. A person with quadriplegia, a woman living with epilepsy, for example. And you'll often see the terms in media and elsewhere that a person is wheelchair bound. And the people that I know who use wheelchairs will say that they're not bound to their wheelchair. They use a wheelchair for mobility, just like we use shoes for mobility. And no one says that we're bound to our shoes, but we often hear that people are bound to their wheelchair. So there are lots of other examples like this that could be given, but it's important to pay attention and try to use terms that are not going to be offensive, at least, and hopefully will be welcoming to people with disabilities. And understanding how patients communicate can be very different. The person on the left, you can see looking up. A lot of people who are nonverbal will use that gesture to mean yes, and no reaction or looking down means no. People can use a speech generating device, as in the picture in the center. And I often think that for a lot of teaching patients, a lot of our patients are less literate, I think, than we might think. And so having, for example, videos about colonoscopies would probably be better for everyone than, or a lot of people, rather than only having print explanations of what procedures are like. And last, I'll say that most of us don't have much training in medical school or other professional schools about taking care of people with disabilities, but you really already know most of what you need to know. The medicine is mostly the same. It's doing away with these other barriers, which are really important in people getting the care that they need. If you want more information about disability competent care, the Colorado Department of Healthcare Policy and Financing has videos that they've developed. Some of the videos contain snippets from doctors you may know. But again, nice short videos that are very instructive about providing care to people with disabilities. And there's a disability competent care assessment tool similar to the one that was used in the study in California that you could use in your own practice to get a sense of what you're doing well and where you could make improvements. This is my contact information. I welcome any thoughts, comments, collaborations from anyone who would like to contact me. And I will now stop sharing my screen and Dr. Campbell will take over.
Um, Thank you, Dr. Martin. I want to begin by thanking Dr. Schwartz, Dr. Ernest, and Dr. Winia for providing me the wonderful opportunity to come to the University of Colorado and serve as their interdisciplinary professor of medicine, and also work with our great group at the Center for Bioethics and Humanities. I'd like to begin with this disclosure that I serve as an expert witness for the government on legal cases involving conflicts of interest between physicians and drug companies. These activities are approved and billed by the OGC at CU. Today, I'm going to be presenting the results of a large NIH-funded study that I'm doing with my colleagues from multiple institutions around the country. The PI is Dr. Lisa Iazoni, and the other members of our team. I'd like to say from the beginning that I am not an expert in disability. I have no lived experience in disability, and I am not a physician. My role on this study was to serve as a survey research expert to design this study to provide high quality data to inform policymaking at this institutional, state, and national level. You'll notice I include here on this slide the amount of this study, because often folks that are not intimately familiar with the practice of survey research assume that all you need to do a survey is a survey monkey or a red cap and a couple of medical students, right? And that's not the case. Survey research is insanely expensive these days, and it requires a large amount of resources to do it. So our goals of our study were to understand the factors that contribute to healthcare disparities for persons with disability, learning from the perspective of physicians practicing in outpatient settings. That is to say, we really wanted to learn about the lived experience of docs and their attitudes and their perspectives and their experiences in caring for these patients. And our goal is to make some feasible recommendations for improving care. The specific aims you can see here, I won't read them, but they were to develop a survey, to administer the survey, and then based on the survey findings and our qualitative work, to develop a toolkit of best practices for reducing healthcare disparities and improving the quality of care for persons with disability. I'd like just to, as an aside, to mention that I heard a very experienced researcher the other day talking about why it's really, really bad to have specific aims that build on each other. And we do this regularly, and our attempt is to make them work with each other, but to do this, you need to make sure that you can adequately address each one. So if you have a very kind of speculative aim, this building, if you will, of aims on top of each other may not be a good practice, but this is how we specified the specific aims for the NIH. So our plan for today, I'm just going to give you a brief overview of this study. I'm not going to go into all the various nuances of what we did and what we found. And I'll provide you with a list of papers where you can see the kind of full body of the work related to this study. So I'm going to start with methods a little bit and spend just a bit of time on them. And I'm going to talk about it from with our survey. So we used a Nashling sampling frame, and our sampling frame was commercially available through a firm called IQVIA. We chose IQVIA as the sampling frame because they have clean, verified lists of all practicing physicians that are verified with claims. They have addresses as well as emails. We sampled 1,400 physicians randomly in a stratified fashion where we selected 350 general internal medicine docs, 350 family practice docs representing the group of patients, the group of physicians that are primary care physicians for adult patients. And then we randomly sampled 140 docs in each of the following specialties: neurology, OBGYN, ophthalmology, orthopedics, and rheumatology. We selected these practices because these are the practices that are likely to see a high number of patients with disability. I'd like to spend a little bit of time on our survey development and testing. We did a tremendous amount of qualitative work up front to develop our survey. The qualitative work was done not only to develop the survey, but to publish qualitative papers from it. We chose phenomenology as a methodology because our intent was to learn about the lived experiences of docs. Initially, we conducted 24 individual interviews with physicians from Massachusetts. This was a convenient sample of both primary care and specialty doctors. The purpose of these interviews was to begin to understand what were the important issues that we should explore. We then conducted 3 Zoom focus groups with physicians nationally that were recruited from CIRMO. CIRMO is a physician panel that have a large number of physicians across the country who've agreed to participate in research. I would like to say that I thought we were pretty cool a couple of years ago when we were using Zoom to do focus groups. Little did I know that by the time the survey came out, everyone would be using Zoom for everything. In addition to that, once we had a draft of the survey, we conducted 8 cognitive interviews to test our survey. And a cognitive interview is just, we ask the doctors to complete the survey, and then we call them up on the phone. And we spend about an hour to an hour and a half going through all of the survey questions, asking them questions like, what were you thinking about when you answered that question? What did that question mean to you? Is there anything in this question that's confusing? And that's just a way to ensure that the people that get the survey are interpreting the question in the way that we as researchers want them to do. We conducted a formal mailed pretest where we actually tested our survey administration with 50 subjects. And we used those data to look at the amount of missing data we might have and to get a general estimate of what we think our response rate was going to be. The final survey had 75 close-ended questions. It took about 10 minutes to complete, and it followed a standard kind of survey format and layout. I would say that I don't recommend surveys of more than 15 minutes. 10 to 15 minutes for physicians is on the absolute edge of what you should do in terms of if you have any hopes of getting a good response rate. The survey was administered by the Center for Survey Research at the University of Massachusetts. CSR, and I have no financial relationship with them, is a professional survey research firm staffed with professional survey researchers who are highly experienced in these types of research. We fielded the survey from October 16th to June 9th. You will notice that we provided a $50 upfront cash incentive that was available with the survey. It came in the mail, and in the mail was a $50 bill. And just in incentives alone, this survey, we spent $70,000 on incentives. We mailed it to doctors, to our participants, with an option that they could respond online. And we did 3 rounds of this over the fielding period. In addition, between the rounds of the survey, which were approximately a month to a month and a half apart, we called we attempted to contact by telephone non-respondents, which means all the non-respondents were telephoned at least 3 to 5 times, trying to get the individual doctor on the phone and ask them to respond to the survey. Some people might wonder, holy mackerel, this sounds like a lot just to get someone to do a survey. And the answer is it is a lot, and it's really expensive. And that's why we use firms like CSR, and that's why we write big NIH grants to get funding to do this. Obviously, we had a slowdown during COVID, and we ultimately overcame it. Our final response rate was 61%. which is generally considered to be the required response rate to have your articles published in some of the leading journals like the New England Journal of Medicine, JAMA, and Health Affairs. Our analyses were conducted by Dr. Rao using Strata and SAS, and all were weighted for the inverse probability of sampling and for non-response within survey strata. Our survey was broad but shallow. We screened out those who were not providing care. We asked doctors about their personal and professional characteristics. We asked them about the accommodations that Dr. Martin mentioned in 5 categories related to chronic mobilities, vision, hearing, serious mental illness, and intellectual disability. We asked about their knowledge of the ADA. We asked about their perceptions of care. And we also asked them about their personal perceptions of patients with disability. And here's what I'm going to show you the findings. I'm going to show you the findings, and we're going to talk about kind of just our marginal findings. I'm not going to go through all of the findings of this study. Here you can see the characteristics of who responded. They were about 38% female, 62% male, which generally reflects the specialties in which we sampled. We had, obviously, as in common in medicine, about 64% of our respondents were white. We had 64% in primary care, because primary care docs tend to respond to surveys more frequently than specialists. About a third were considered young, that is, within 20 years of graduating from medical schools. The vast majority practiced in the community. We had a nice split in terms of small practices, of very small practices, and large practices. We tried to split it. It was divided evenly into low, medium, and high groups in terms of the number of patients. And we also looked at safety net providers. Here's our key findings, which will just give you a foreshadowing of what is to come. These key findings were published yesterday in the journal Health Affairs. And I'll provide a link to that at the end of the talk. So the first thing we asked about was we asked physicians about their ability to provide the same quality care to patients with disability as they provide to patients without. And you can see here, slightly less than half felt very confident that they could provide equal quality care to patients with disabilities. And approximately half said were somewhat confident that they could do this. Only 10% reported not being very confident or not at all confident. We then asked about quality in the overall healthcare setting. Thinking about the broader system of care, how would you rate the quality of care patients with different significant limitations, different disabilities receive compared to patients without? And you will notice here, first of all, I want to just point out a few things. You will notice here in general, except I have to move this so I can see that, that about a third of doctors felt in general that patients with disability received much worse care than patients without. A little less than half said patients in general with disability receive a little worse care. And you will notice that this varied significantly depending on the disability, with respondents feeling that patients with serious mental illness and intellectual disability they were much more likely to say that they received much worse care in general. And I would also point out that these bars on the bottom, you will notice that small, it's gone. I don't know where it went. Okay, well, we'll skip that. There it is. You will notice that a small percentage felt that patients with disability received better care, and relatively around 40% felt that they received at least the same care that patients without disability received. As Dr. Martin mentioned, having accommodations, often referred to as durable medical equipment, is important. We asked about the existence of height adjustable exam tables. We asked about measuring, about roll-on weight scales. We asked about Hoyer lifts. Here I present the data on measuring weight. We found that among our participants, with regards to patients with disability, only 64.8% said they routinely measured weight. That is not surprising given that some of our, respondents were ophthalmologists and things. But among those that did, 26% said they always or usually use a weight accessible scale. So about a quarter say they use a weighted, an accessible weight scale for patients with significant mobility limitations. We asked what they do when they don't use those scales. And 8.1% said they always ask patients, 24.3% said they usually ask patients, and 40% said they sometimes ask patients. And I was reminded by one of my clinical colleagues to reinforce the fact that self-reported weights have been shown to underestimate weight among persons with disability. And then we asked about their perceptions. We asked this battery of questions that read, to what extent do you agree or disagree with the following statements? The response categories were strongly disagree, somewhat agree, or strongly agree. We found that about 80% of physicians strongly agreed that understanding their patients with disability was valuable to them as a physician. We found that approximately slightly more than half strongly agreed that they welcome patients with disability into their practice. We found about half felt that patients with disability are often treated unfairly in the healthcare system. And then we sought to explore, some potential reasons, and very few physicians strongly endorse the idea that patients with disability are non-adherent because they lack support, and that very few felt that the treatment of patients with disability was too time-consuming. We then asked about the quality of life, the perceptions of the quality of life in general compared to persons without disability. Do you believe the overall quality of life of persons with significant disability is a lot better, a little better, the same, a little worse, or a lot worse? You'll notice here that approximately a third of physicians believe, 37% reported that the quality of life of persons with disability was a lot worse than persons without. 42% reported a little. Only 12% felt that the quality of life was the same. If you step back for a minute and think about this from a sociological perspective, this is a very skewed distribution. If you ask people in general, think about a neighbor and who's like you, and say, what do you think about their quality of life? What you expect to see is that the majority will say, well, their quality of life is about the same for me. And then, a few will say it's a little better, a little worse, and very few would say it's a lot worse. And yet here, in this case, we see that doctors seem to endorse this belief that the overall quality of life of persons with significant disability is worse than patients without. This is despite substantial evidence in the literature that when you ask patients, they believe that they have high quality lives. And this was one of the main findings that's highlighted in the paper that came out yesterday. We asked doctors about their obligations and knowledge of those obligations under the ADA. Dr. Martin talked about this, right? And so we asked, how much do you know about your legal obligations as a physician under the ADA when caring for patients with disability? About 14% said a lot. Approximately half of respondents said they know something. a quarter said they know a little, and 8% said they knew nothing at all. And so I'd like to summarize these findings for you. You know, basically, we found widespread evidence of biased attitudes and beliefs of physicians regarding patients with disability. These related primarily to perceptions about the quality of life that that doctors hold. We found that less than half of physicians were very confident in their own ability to provide equal care to patients with disability. Only 56% strongly welcomed patients into their practices. We found a documented use in this kind of series of studies about a lack of access to essential medical equipment and care. We found that even when physicians have this accessible equipment, they're not always used. And we found that practicing physicians in our study might not fully understand their legal responsibilities when caring for persons with disability. The next steps, clearly, we think that formal training in effective methods is important to do. It may not be the most important, but it is important to consider. Clearly, further education around issues of the American Disabilities Act and other disability civil rights laws may be warranted. I believe, and I think my colleagues believe, that we need to begin to address the fact that persons with disability report that they have high quality lives, and it's up to physicians to understand and accept this fact. This study has prompted 2 follow-on R01 applications related to the experience of caring for rural patients with disability, and also understanding the factors that predict biased attitudes and practices towards disability. 2 weeks ago, the Civil Rights Office at the Department of HHS has launched a major new program, and I will just highlight the fact that the start of this process is to write new regulations that expressly prohibit medical workers from denying care to people with disabilities based on subjective decisions about the quality of their life. Here are the papers that emerged from our study. I highlight the middle one, which was selected as one of the top 10 articles in Health Affairs in 2019. The last one is the paper that just emerged yesterday. I want to acknowledge the real expertise of Dr. Martin and Dr. Morris here at CU. They are the true experts in disability research and practice, as well as Dr. Iazzoni at Harvard Medical School. And with that, I will close and unshare.
Okay, well, thank you very much, Eric and Barry. This was a really provocative series of talks on an important topic. Let me ask a few questions. I'll start out with a very practical question. If we notice a infrastructure constraint that limits the access of our patients or our colleagues to certain facilities, where do we go with that? Who should we notify, and what kind of responses should we expect?
Well, I can tell you that in my experience, when I talk to administrators who, for example, are building new buildings, the new facilities, and we point out that you need to make this facility accessible to people with disabilities, you need to have height adjustable exam tables and overhead lifts, and they'll say, well, that's not in the budget. That would be an extra thing that we didn't budget for. And my thought is, it's the law that you have to. How can you not budget to be in compliance with the law? Certainly, I would say in your own setting to point out to your administrators, whoever that is, if there are issues that are not, that make your site not as accessible as it should be, take proactive actions to try to change that.
So are there any funds available through the ADA that help renovate facilities to make them more accessible?
My understanding of the ADA is that it's unless it poses an undue burden on the facility, that it's the obligation of the facility, the institution, to make these changes. And I would say that most, quite a few of these don't cost anything. Having a better attitude about people with disabilities and communicating better about people with disabilities doesn't cost a penny. Other accommodations, such as wheelchair scales and height adjustable exam tables, are not very expensive, accommodate all of our patients, including elderly patients who often have mobility challenges. And so it's unclear to me how we can not do it, not how do we find money to do it.
Mhm. So tell us a little bit about the diseases that we should think about that are disabling. It would seem to me that almost all of the chronic diseases that we take care of are disabling. And many of the behavioral issues that we're faced with when we take care of patients are disabling, like alcoholism and cigarette smoking, maybe as it relates to mental health concerns and things like that.
I think you're right that, all of those conditions can cause disabilities, can lead to barriers to access to healthcare. Some, for example, cigarette smoking is a tremendous detriment to health, but cigarette smokers probably don't experience more barriers to access to healthcare than do people who don't smoke cigarettes, as opposed to people with intellectual disabilities, for example, who might have lots of barriers to access to care for the reasons we talked about. And so is it the disability the person has, or is it having universal access in all ways? All of our tables are accessible to all of our patients. All of our doors can be opened by any of our patients, et cetera, that we don't think about every single disability. We think about how can we make our facilities accessible to everyone, no matter what disability they might have.
And what about those implicit biases that we tend to have in terms of addressing concerns that disabled individuals might have? How deeply rooted are they, and how can we deal with them effectively to address our patients in a much more constructive way?
I think
Take that one,
there's,
Eric.
sure. I think that some of these biases are known to the individuals and some of them are not. Some of them are deeply hidden below the consciousness of what individuals often recognize. And I think that the key is part of the reason we did this study was not to poke our finger and to make doctors feel bad. It was to begin to put point estimates on the frequency with which people hold these perceptions that are problematic. And so for that reason, our wish is to bring these to light and to estimate them. But clearly, Dr. Morris's work, for example, shows that that you can measure these implicit biases and that bringing them to light is the first step in addressing them. Because if they're not brought to light and they're not quantitated, often people believe that, well, only a few doctors feel this way, or this is not common and this is just a bad person. It's a fact that these are feelings that exist among the physician community, but they exist probably among every kind of in our community. So physicians, while we like to believe are unique and kind of exemplary, in this case, it just is what it is.
So Eric, a follow-up technical question related to your survey. How did you measure implicit bias, and did you develop your own tool for doing that? Are there tools available?
Sure. There's a number of existing scales for measuring bias in surveys. I reviewed those existing scales, and we thought that we could likely do a better job. You know, the rule of thumb that many people endorse is, well, this has been used before, so I should use it. But if it's not good and it doesn't measure what you want it to, then you develop our own. So we developed a set of multiple items that measure underlying bias, one of which is, do you believe that persons with disability have a lower quality of life than other people? That is essentially measuring an underlying belief about quality of life. We asked questions about whether, you know, they think that people are non-adherent, right? So we had a series of 5 questions that we used. We didn't attempt to scale them. We used them as single item indicators. We've only used them once, and we haven't correlated them yet with outcomes, but they're predictive of a final outcome, which we used, which, you know, are you welcoming patients into your patients with disability in your practice? And we found that doctors who held these kind of underlying potentially biased views were less likely to say that they welcome patients with disability in their practice.
Mhm. And related to that, what about the perception of patients and their families in terms of disabilities and how they're cared for? Are there 360s being done to try to figure out how the recipient of care and the families that are impacted by this are responding to the types of constraints that they see in healthcare delivery?
Yeah, I don't know if there are 360s that are done that specifically link the patients to the doctors, but what I can say for certain is that there is substantial work studying this among the community of persons with disability, their family members and caregivers, and they report often feeling that their caregivers were in some, you know, held some views against them that they didn't appreciate, and they often self-report disparities in care. And Barry, you should talk to that because you're an expert there.
Well, I certainly hear that from patients quite a bit about barriers that they've experienced in other places. And I think one of the striking things to me are patients who are transitioning from pediatric care into adult care. Very often these folks, you know, with significant disabilities have been involved with, for example, Children's Hospital of Colorado from prenatal on through turning 21, a very welcoming, caring community within Children's Hospital of Colorado. And then they sort of fall off the cliff into the adult world where it can be hard to find primary care docs, hard to find specialists, hard to find people who understand the condition that this person is living with. So yeah, there are quite a few barriers and perceptions on patients' side about whether practices are welcoming, and they may look around and say, you know, the pictures I see on the walls are all able-bodied people. No one looks like me in those pictures. I don't see any person with a disability working in this institution. I don't know how they can relate to me if not a single person here appears to have any disability.
This is not meant as an excuse. It's just meant as an observation. And the observation is that disabled patients are not commonly seen in clinical practice, in most clinical practices. And the issue then becomes the infrequency of that experience then makes it difficult to develop protocols related to care of disabled individuals. How would you respond to that, Barry?
Well, if you recall the slide I showed about the prevalence of disabilities, you know, we take care of quite a few older patients, 70 and older, for example, and the frequency of significant disabilities among that population, I think, as I recall, over 80, it's people over 80 is 50%. have a severe disability, and people, 70 to 80 are in that same category. So I think part of it is we don't recognize that a lot of the patients we take care of have a disability, and the person with a disability has to adapt to our systems. And many can, but some can't. And why do we not have more patients who use wheelchairs in our facilities? Maybe because they can't get in, they know they won't be able to get the kind of care they need, won't be able to be transferred to an examination table to have the same exam anybody else does.
Mhm. Are you aware of specific training programs for our trainees and faculty to learn better how to care for individuals with disabilities?
I know I've been involved in some efforts with the new curriculum at medical school on including issues about people with disabilities. I know in several other locations, model patients for exams, for example, as an example, would be some of the patients be people with disabilities. So there are a lot of ways of exposing, including having co-learners who have disabilities themselves. So the more our training programs are open to people with disabilities, people who don't have a disability will be exposed to them, and the more we can include issues related to people with disabilities, disability as access as a civil right, I think people will get excited about that and want to do something about it. I think it sometimes doesn't get the same attention that some other populations get in thinking about how do we remove barriers to access, but it's such a common condition among people. We need to do more.
Yep, you're absolutely right. We do need to do more. Any closing remarks either of you would like to make? No. Okay.
Thank you for allowing us to present.
And it's just the beginning. So we need to do this again. Thank you very much for participating in this. It was 2 great presentations.
Thank you, David.
Bye-bye.
Thank you.